I thank the organizers for inviting me for this talk. Congenital anomalies, the ultrasound of congenital anomalies is important because in minor anomalies it affects the perinatal, the neonatal management, and in major anomalies it gives the parents chance to terminate the pregnancy, the option to terminate the pregnancy. The purpose of obstetrical ultrasound is location of the pregnancy, whether in the uterus or the ectopic pregnancy, the age of the gestation, fetal viability, number of the fetuses, whether single, twin, triplets, presentation of the fetus, site of the placenta, whether high-lying or previa, measurement of the amniotic fluid, estimation of the fetal weight, and detection of the fetal abnormalities. At 5 weeks, the gestational size is gestational sac is 1 centimeter in size. From 6 weeks onwards, we can see the embryo. The CRL can be measured from 7 weeks onward. How you measure the CRL from the crown to the rump in this 8-week embryo. In the first trimester, we can detect certain anomalies. At 11 weeks, this is a normal fetus at 11 weeks, where you can see the cranium, the skull bone very well. However, acrania is the absence of the skull bone, and here you see no skull bone, and the brain is exposed to the amniotic fluid. Ultimately, it will progress to anencephaly. In anencephaly, we do not see any skull bone or brain. The cerebellum and the brainstem is, however, present. Most of these fetuses die within few hours of the birth. So it's important to terminate the pregnancy. Cystic hygroma is a congenital lymphatic malformation occurring in the cervicofacial region. It occurs in 0.3 to 2% of the pregnancies. It is associated with the Turner syndrome, Down syndrome, congenital cardiac anomalies. Here you can see a cystic lesion at the back of the neck. Sometimes it is an isolated finding. It may not be associated with other congenital anomalies. In that case, it has a better prognosis. So you have to look for other anomalies as well. Knuckle translucency is collection of fluid under the skin behind the fetal neck in the first trimester of the pregnancy. This is a normal knuckle translucency measurement. Here, how you measure it, the fetus, the head should be in the mid-sagittal plane. You should magnify the image to include just the head, neck, and upper chest. This fluid should not be more than 3 millimeter. If it is more than 3 millimeter, it may be associated with other chromosomal abnormalities, with cardiac defects, and with trisomy 21. Nasal bone, we can assess that in the from first trimester onwards. The normal nasal bone, you see an equal sign. This is the nasal bone, this is the skin overlying that, and that is the nasal tip. Its absence maybe is associated with trisomy 21. Here you can see nasal bone is not seen. You cannot see the equal sign. In 1.2% of the fetuses, they may have a hypoplastic nasal bone, but around 60% of the fetuses with hypoplasia are associated with Down syndrome. So you have to look out for other anomalies of the Down syndrome. Polyhydramnias is not an anomaly, but it can be associated with anomalies. 60% of the cases of polyhydramnias are idiopathic. 20% are due to maternal causes, for example, diabetes, and 20% are due to fetal anomalies. Now, what fetal anomalies are associated with polyhydramnias? There can be CNS anomalies like anencephaly, ventriculomegaly, Holland-Prosencephaly, Danty-Walker syndrome, meningomyelocele, encephalocele, agenesis of corpus callosum, cleft lip and cleft palate, CPAM, cardiac anomalies, GIT anomalies, skeletal dysplasia, chromosomal abnormalities, as well as twins. Fetal ventriculomegaly is diagnosed when the diameter of atrium of the posterior anterior horn is more than 10 millimeter at any point of gestation. In the first trimester, you would see the choroid plexus filling the ventricles. In the second trimester, the choroid plexus would recede posteriorly, but would still fill the ventricles, and you will not see gaps between the walls and the choroid plexus. And as the pregnancy, and in case of ventriculomegaly, this is a normal 5 mm lateral ventricle atria of the lateral ventricle, and the choroid plexus is normally filling it. In that case, you see that it is 1.5 centimeters. It is 15 mm, it is dilated, it may be associated with other anomalies, and you have to look out for other anomalies, particularly the spine abnormalities. What is the normal appearance of the spine? In normal appearance of the spine, you would see that the posterior elements are converging. And on sagittal view, you would see two parallel lines which taper distally. In case of spina bifida, which is a neural tube defect, neural tube gives rise to a vertebral column and the spinal cord. Here you would see the posterior elements are diverging. They move apart, and cystic contents containing CSF or the meninges would come out of the spinal canal and would lie beneath the skin. For example, in this case, you can see that. So the diagnosis of that anomaly timely at 20 weeks is absolutely important. Cavum septum pallidum, it is a structure where we measure the biparietal diameter. You go from bone to bone, head circumference is measured, outlining the skull. Cavum septum pallidum is a fluid-filled space between the leaves of the septum pallidum. Its absence is associated with corpus callosum agenesis, septo-optic dysplasia, ornate Chiari malformation, schizencephaly, and hollow prosencephaly. In agenesis of corpus callosum, there is absence of the cavum septum pallidum. Here you see there is no cavum septum pallidum, and the ventricle assume teardrop shape or configuration and dilatation. In Chiari malformation, the cerebellum and the hindbrain protrudes into the spinal canal, but you can see a lemon-shaped skull in case of Chiari malformation. Both the frontal bones are pinched. And in the posterior fossa, you see that the cerebellum assumes a banana sign. Here it is opposed against the brainstem, and it gives rise to banana sign. So these two signs are important as regards the Chiari malformation. Hollow prosencephaly results from the incomplete separation of the cerebral hemisphere. Here you see a monoventricle. The thalami are fused, and there is no central fox. It is also associated with facial anomalies, for example, proboscis in this patient. And encephalocele is in that there is a defect in the skull, and through that defect, CSF and the brain tissue can herniate, or there could be a meningocele where only CSF can herniate. Dandy-Walker malformation, in that case, there is hypoplasia of the vermis, and there is cystic dilatation of the fourth ventricle. There is marked enlargement of the cisterna magna, more than 10 mm. There is trapezoid gap between the cerebral hemispheres. Cleft lip, this is a case in which there is a cleft in the upper lip of the fetus. This is the nose, this is the chin, and cleft is located left of the midline. Now, cleft lip may be an isolated finding or it may be associated with other anomalies. If it is an isolated finding, it can be repaired afterwards, after the birth. Regarding the heart, the assessment of the four-chamber heart is very important. The heart lies in the chest, making an angle of around 45 degrees with the chest wall. The four chambers are almost equal in size. The right ventricle is opposed against the chest wall, the left ventricle, the left atrium, the right atrium. The tricuspid wall is slightly offset compared to the mitral valve. There is opening of the foramen ovale, and the leaflets point towards the left atrium. The heart should occupy 1/3 of the chest. It should not be more than that. If it is enlarged, you have to look out for other anomalies. Four-chamber heart would help you in assessment of VSD, intracardiac echogenic foci, which is associated with trisomy 21, hypoplastic left heart. When you see the four-chambered heart, you rotate the probe towards the patient's, towards the fetus left shoulder, and we get the left ventricle outflow view. Left ventricle outflow view, here you can see left ventricle leading to the aorta. The aortic wall should be in continuity. The aortic wall should be in continuity with the interventricular septum, and if there is any discontinuity, it would indicate VSD. Also, it helps in evaluation of transposition of great arteries if the left ventricle gives rise to the pulmonary artery. In right ventricle outflow view, how you take that? First you get a four-chambered view, and then you rotate the probe towards the fetus right shoulder. Here you can see right ventricle giving rise to the pulmonary artery. Pulmonary artery, there is the right branch of the pulmonary artery. Here is the ductus arteriosus, and that is connecting the pulmonary artery to the dorsal aorta. Then comes the three-vessel trachea view. Three-vessel trachea view, in that from left to right, you would see, you just move cranial to the four-chambered view, and you get the three-vessel view. In that case, you see a pulmonary artery, aorta, and SVC. The pulmonary artery diameter and aorta are almost of the same size. Look out for that. If there is any discrepancy, look out for any abnormality or absence of the thymus, because that would be associated with congenital anomalies. The trachea is lying posteriorly and esophagus further posteriorly. Also look out for the position. There is the ductus arteriosus that unites pulmonary artery with the aortic arch, and it forms almost a V-like confluence. Coarctation of aorta, the pulmonary artery and aortic diameter would differ. Congenital pulmonary airway malformation, there is abnormal proliferation of the bronchial tissue. Here you see it has varying degrees of the cyst formation. In this patient, there are small cysts which give rise to the echogenic lung. Echogenic lung is pushing the heart and it is squeezing it along the chest wall, and here you see the normal right lung. You also look for any diaphragmatic hernia. Here again, the heart is squeezed against the chest wall, and there is a herniation of the bowel, the liver and gallbladder. They are lying alongside the heart. Four-chambered heart view. Abdominal circumference, how you take that? You map out the umbilical vein and portal vein confluence, and this view should also include the stomach. Then the outer wall is mapped for abdominal circumference. If you make an abdominal circumference, you do not see a stomach, and there is excess amniotic fluid, suspect tracheoesophageal fistula. In case of duodenal atresia, you would see a dilated stomach and dilated proximal duodenum, and that gives rise to so-called double bubble sign. We call it double bubble sign. If you see a cystic dilatation like this, always refer for detailed anomaly scan because it can be associated with trisomy 21. In omphalocele, there is congenital midline abdominal defect at the base of the umbilical cord insertion. It may contain bowel or it may contain liver as well. It is covered by the membrane, and the umbilical cord is seen arising from it. It is associated with other anomalies as well. Look out for the other anomalies. In gastroschisis, on the other hand, there is herniation of the bowel loop, and herniation is para-umbilical. Here you see the umbilical cord, and the herniation of bowel loops is on side of the umbilical cord, and the umbilical cord is not covered by any membrane in this case. This is also associated less so with other anomalies. The physiological bowel herniation occurs up to 11 weeks, and it should not be seen after 11 weeks. If it is seen after 11 weeks, you have to get suspicious about that. Oligohydramnios is important in evaluation of the congenital anomalies. Oligohydramnios is associated with IUD, with renal anomalies, with IUGR. The patient could be post-date. There could be premature rupture of the membrane, or there could be chromosomal abnormalities. Fetal pyelectasis, normal measurement of the anterior-posterior diameter of the renal pelvis is less than 4 millimeter from 16 to 27 weeks, and less than 7 millimeter 28 weeks onward. That's very important. And if it is more than 4 millimeter or more than 7 millimeter, there is hydronephrosis. If it is more than 10 millimeter persistent in the third trimester, then it is persistent hydronephrosis. It may be associated with oligohydramnios. If you see fetal hydronephrosis, you should always look out for the posterior urethral valve, pelvic-ureteric junctional obstruction. Look out in the bladder for the ureteroceles, and there could be other causes, for example, vesicouterine reflux, or could be congenital anomaly like Prune-Bailey syndrome. The normal renal size from 20 to 40 weeks of gestation corresponds to the week of gestation. For example, at 20 weeks it would be 20 mm. At 40 weeks it would be 40 mm. But it should not be more than 5 centimeters. At all costs, it should not be. If it is more than 5 centimeters, it is suspicious. Look out for the size of the kidney and also its echogenicity. In autosomal recessive polycystic kidney disease, the kidney is enlarged more than 5 centimeters, and it would be echogenic, and it would be associated with oligohydramnios. Kidney would not be functioning, and it is mostly lethal. When you measure femur, do not include the greater trochanter, do not include the spur artifact. Just measure the diaphysis. If in skeletal dysplasia, the femur or the humerus, it may be very short. A rule of thumb is if the extremity measurement is less than 5 weeks, then expected, you suspect a skeletal dysplasia. There are other criteria. Various authors have given various criteria. For example, femur length, foot length. If the ratio is less than 1, that is also indicative of skeletal dysplasia. Sometimes the skeletal dysplasia is associated with short circumference of the thorax. For example, less than 5% for the percentile for the gestational age. In that case, it may be associated with lethal dysplasias like thanatophoric dysplasia. While evaluating the limb, always count the fingers. Here you see the fetus has 6 toes. In the hand, the fetus has 6 fingers. Polydactyly may be an isolated finding or may be associated with other congenital abnormalities, for example, Macaulay-Gruber syndrome. So you have to look out, you have to count the fingers. As regards also see for any inversion of the foot, if there is a persistent inversion of the foot is that would give a persistent hockey stick appearance, which would suggest a club foot. So look out for that. Sometimes clubfoot is an isolated abnormality, in which case it would be treated after the birth, or it may be associated with other anomalies. Hydrops is not a congenital anomaly, but it may be associated with that. Hydrops is an excessive extravasation of the fluid into the third space. Two of these criteria must be present, that is fetal pleural effusion, for example, in this case, fetal pericardial effusion, fetal ascites, for example, in this case, generalized body edema. Here you can see there is body edema, placental enlargement, polyhydramnios, and hepatomegaly. And the causes of hydrops are immune. It may be associated with rhesus incompatibility, or it may be non-immune hydrops fetalis. In that case, it may be associated with chromosomal abnormalities or with cardiac abnormalities. Thank you very much. Where in doubt, always refer for the